Welcome this afternoon. Our topic today will be practices that can enhance spirituality in healthcare. Last week we looked at suffering and spirituality, and what we discovered was that many patients come into the hospital. Of course, they get their biomedical treatment from the doctors, nurses, and staff. But what happens is they may have issues going on much deeper than their medical condition. In fact, their medical condition may have impacted them individually as far as their future goals and things they can accomplish individually, may affect their family. Wife may or spouse may have to go to work, or who's going to take the children to school at 7 o'clock in the morning. And then also there are what I call ultimate needs that come to light if they're discovered. In other words, how does the patient feel? Did God let them down? Why did this illness happen? So what we're going to look at today are some practices that can enhance the ability of us to be able to identify these situations in the life of patients and then what to do about it. So I think it'll be an important talk, and I'm glad you're here to listen to it. As you see on this slide, we're now in about the 5th talk in our Spirituality and Health series. We've also completed the World Religion Study by Dr. Ferdos. Next week, we will look at spiritual care of the aging at the end of the life. Then we're going to look at creating a spiritual environment, and finally, the psychology of religion and spirituality. So there's some interesting things coming. Today, what I want to do is look principally at 4 areas. First of all, I think in order to enhance spirituality in healthcare, the first thing we've got to do is recognize healthcare is a calling, and it can be a sacred vocation. And then second, I want to look at a 4-step process that can help us enhance spirituality. And then some training that may be necessary in order for caregivers to be effective. And then finally, how we will put this on the care team's agenda in a hospital setting. There are a lot of books that are out now that address this subject, and these two, Making Healthcare Whole and The Spiritual Challenge of Healthcare, are wonderful. I highly recommend them. These 2 books are interesting, Positive Spirituality in Healthcare. This one looks at 9 practical approaches to pursuing wholeness for clinicians, patients, and healthcare organizations. And then Kenneth Pargament, our distinguished scholar at the Institute, has written this book, Spiritually Integrated Psychotherapy. And if you can integrate psychotherapy with spirituality, then you ought to be able to integrate the hospital. And then finally, there are 2 really outstanding books by Harold Koenig, who's done work in this area for 30 years. One of them is entitled Spiritual Caregiving, and his subtitle is Healthcare as a Ministry. And then the other one that is excellent is Spirituality and Patient Care. So I recommend all of those. I want to say that fundamentally, when we want to offer spiritual practices in healthcare, the concept of having some sense of calling is important. In other words, feeling called to this chosen field. Caring for the sick and ill is more than just those biomedical exercises that we do in the hospital. And in fact, true healing probably doesn't happen unless we get beyond that. And having a sense of calling to medical care helps one to understand healing is more than science. Healing involves caring for the whole patient. And by that I mean ministry to the patient's not only body physically, their soul, their psychosocial area, but also their spirit. I want to give you some 3 or 4 steps. One of them that we're going to call enhancement number 1 is, in fact, looking at the fact that medicine can be a calling. At the Institute, we did a survey of physicians in our Harris County Medical Society and learned that 85% of our physicians felt, in fact, that they had a call to medicine. We didn't ask them to define what that meant, but the point is they felt drawn and called to this work. 70% of them said they prayed regularly for their patients, and 50% said they experienced God's intervention in the care of their patients. In fact, an oncologist said, "You can't care for cancer patients and not see the miraculous taking place," he said, every day. I want to mention Christina Puchalski. She's one of the principal people today in this area. She's an internist at George Washington University School of Medicine. She says spirituality is the thing we all have in common. It's a search for meaning in a person's life. It moves us outside of ourselves to other concepts that can be found in religion, in nature, in relationships with others. So it's not exclusively religion. Spirituality is broader than the concept of religion. It has also been said that the spirituality of a person is like a fingerprint. We all have a unique spirituality. It's unique to us because we experience different things in life. We can connect because we're spiritual beings, even if we don't acknowledge that we're a spiritual being. Here's what a Dr. Herman Brecker, a Jewish internist in Cantonville, Maryland, said, "Morally and ethically, I try to treat my patients and others as I would like to be treated. This has taught me religiously and in other ways, and probably has the greatest effect on my interpersonal dealings." And of course, I think we'd all see that as the golden rule. I will do unto others as they would have do unto me. And what an excellent principle, guiding principle for medicine. I believe I have time to tell this story. This is a parish nurse. Carol Story is her name. She says, "On one occasion I was talking to a patient dying with cancer. The man had earned his PhD. He dedicated his life to teaching. He was questioning the values of his life. Had he made a difference? What did his life mean? He spoke a long time about his life. He shared that when he was 15 years of age, a pastor in his church had embarrassed him in front of the congregation, predicting he would never make anything or be anybody of significance. He reflected that he had taught a few students that had moved on to be leaders in sports and education. Carol's story says, as I listened to all that he shared, I sensitized what I was hearing. What I am hearing you, she said to him, what I am hearing you say is that you always felt unworthy of any praise because what one man had said to you as when you were a young man. And the patient looked at her, the nurse, and said, yes, you put into words something that I have struggled with for years, but it is true. I have always wondered if I measured up and felt unworthy. Thank you, he said. God loves you, the nurse said to him, and I believe he is going to say, well done, thou good and faithful servant. By the way, she was quoting a verse of Scripture. The man grabbed her hand and said with tears, thank you, and then asked me to pray with him. I want to tell you, that's a little powerful story of one parish nurse and the difference that she made in the life of that patient, and that's what spirituality and patient care ideally should be like. I have another story, but it'll take a little long to get to that one, so I won't do it. Harold Koenig, in his book Spirituality of Caregiving, gives us 10 characteristics of someone who is a ministering person. Doesn't have to be a doctor or nurse, but just anyone. First of all, he says it is the ability to enter into a relationship with another person, share that individual's pain, listen, even when it causes some inconvenience, to say little or nothing, and at other times to raise questions for reflection. Second thing he said is that a ministering person takes the role of a companion on another's journey rather than being a problem solver or rescuer. And doctors are trained to solve problems, so it's hard to take this companion role, but we can all learn it. And third, the ability to love the unlovable, the ungrateful, the uncooperative, the aggressive, the unreachable. That would be difficult, but a ministering person has to be able to do that. Fourth, he says, is that we accept our own brokenness, our own humanness and fragility so that we can enter into the relationship with those who are burdened with difficulties in their life. Gives the freedom, when we can do that, to cry with a person in sorrow. Have you ever seen a doctor cry with a patient? I have. I actually did. What happened was a baby was born. Little baby was premature, so premature that the child was, the fetus was dead at the time, but the mother was deeply moved by this loss. I was in the room because of being a pastor, and the doctor wept with her. I thought it was a very powerful experience. He says to be able to cry with a person in sorrow and then rejoice when one meets success, to share their anger over injustices, to accept the doubts and confusion caused by the events of life. All of that is ministering to someone. Fifth, to be a facilitator of change in others, but not assume responsibility for that change. We can do that by giving other choices. Quite often when people are in difficulty, they narrow their choices. They think this is the only option. So giving other options is very helpful. Six, a ministering person will allow others to make decisions and support them in that process. Seventh, they will accept the solutions to problems best arrived by the patient served and won't try to manipulate or control the situation. Eighth is the ability to recognize that one cannot put an end to another person's psychological pain and suffering, but we can be a witness to it and give voice to that suffering. In other words, say, I can see you're really suffering. This is really difficult for you. Ninth, the ability to accept others the way they are, make no attempt to fashion them into different people. And finally, 10th, the ability to encourage others to delineate their own values, goals, and personal views. That's a very helpful growth step in the life of a relationship with anyone. And if you minister to people, it's a fun thing to talk. What are your values? What are your goals in life? What are your personal views? And get to understand and not try to change them, but let them formulate them, because it gives them identity and gives them meaning and purpose. They see they're related to those values and those goals. So recognition that as a healthcare professional, one is called, and that healing is a sacred vocation, I believe enhances the caregiver's recognition that spiritual needs are important to be a part of the holistic patient care. In other words, we talk in medicine about biopsychosocial, but we need to add the word spiritual to it. When we are approaching a patient to be holistic, it really is biopsychosocial and spiritual. The second enhancement approach is to have a four-step process to identify and care for spiritual needs. Simply to be happenstance or to allow situations to arise and deal with them individually is not the best approach. We don't do that with any kind of informed patient care. No other aspect of patient care is handled that way. We always have some plan and a process to meet that need, and we need to do that with spirituality as well. So we need to commit to a process that will help identify patients' spiritual needs and have a plan for what to do when those needs are recognized. I want to suggest this four-step process, which has been recommended in the book that I showed you, entitled The Spiritual Challenge of Healthcare. It's a four-step process, fairly simple: assessment, planning, implementation, and then evaluation. I want to say the principal assessment tool for spirituality begins with the caregiver, him or herself. It's listening, being able to actually hear what the patient is saying. Look for their tone of voice, the speed in which they're speaking, and what is happening when it is said. What are they doing? What are their gestures? Determine how the patient is communicating also with the family members. Talking with family relatives and friends will enlarge that picture and judge whether or not the patient is troubled about something or not. If you don't sense anything, that's great. You've listened. You've observed also. There are all kinds of nonverbal cues that may give a key to where the patient is spiritually, whether or not they have a sense of well-being. It may be a gesture, maybe a look. You may ask a question, the patient may turn away from you and face the wall. How does the patient respond when hearing bad news? Or a difficult treatment is about to be begun or there is needed? How do they respond to those things? The third thing is communication, and I'm going to discuss this in a little more detail later, but by continually visiting with the patient, we develop a relationship of trust, which is vitally crucial to this whole assessment process. Dr. Harold Koenig, in his book, Spirituality and Patient Care, talks a lot about taking a spiritual history. He says addressing the spiritual needs of a patient means that physicians must learn to take a spiritual history in a manner that is patient-centered and respectful of the patient's needs. The spiritual history provides information relative to patient care. It's not that it's separate from the biomedical process that's going on. It's actually relevant to it. It communicates to the patient that the physician is also open to addressing this area that is spirituality, and that's a vital, important part of asking us, going through a spiritual history. And for all but the most simple needs that arise during an assessment, referral to a chaplain or pastoral counselors may need to be considered. So the doctor doesn't have to feel like, oh, this is going to open a kettle of worms and I don't know how to solve it. He can always bring in professional, trained people. In special circumstances and with the patient's permission, the physician may even consider praying with the patient. There are times in which you see the patient is hurting, is wounded, maybe feeling alone, there's nobody there. It might be nice to say, would it be okay if I pray with you at this time? And a simple prayer. Lord, I know you know this man, this woman. You know where they are. I just pray that you be with them and give them your comfort. It can be that simple. And often by the end, the patient is weeping. It is so powerful for a patient to have a physician or a nurse that cares enough to want to pray with them. Koenig has a chapter in his book, Spirituality and Patient Care, that lists a number of assessment tools. There are these inventories. There are lists of what are spiritual histories. They're all, these are listed here for you. The HOPE questionnaire is often used. And I want us to look at the last one, which is called the American College of Physicians, also the American Society of Internal Medicine have come together with which is what is called a CP, spiritual history. And they suggest 4 simple questions to ask the patient with a serious medical illness. I don't know why it has to be so serious, but they qualified it that way. The question was, is faith, that is religion and spirituality, important to you in this illness? And what that's really asking, does the patient have spiritual beliefs that might influence their health care? They may have strong beliefs they don't want to receive blood, as we know, some patients don't, and they may not want, they may be wanting to trust in God and not in medicine, or it may be a struggle they're making there. So asking the question can be very important. Second, has faith been important to you at other times in your life? Which is trying to get at, does the patient use religion and spirituality to help cope with an illness or when experiencing stress? And how do they do that? And the next question is, do you have someone to talk to about religious matters? In other words, does this person have a religious community, a connection with pastors and a rabbi and an imam in their own religious community? Would you like to explore religious matters with someone? In other words, does the patient have troubling spiritual questions or concerns, and chaplain could be invited to come in for a visit. So those are 4 things, and I like the fact that that this is. I like the fact that it was the Academy of Internal Medicine that recommended it. But what if the patient is not spiritual? They let you know right off. I have no interest in religion or spirituality. Dr. Koenig says this really doesn't let us off the hook. We simply need to change our tactic. We may want to ask instead, how do you cope with an illness and stress in life? You may ask, what gives your life meaning and purpose in the face of this illness? I mean, particularly if it's a serious illness, maybe they've been paralyzed, maybe something has happened tragically, or they've been diagnosed as cancer. Another question you could ask someone that's not religious. Do you have social supports that help your family provide support at home? Some families have almost no connections with anybody, even their own blood relatives, so it's a good question, and it may even reflect why this person has no interest in religion and spirituality. They may have had a church setting in the past and were hurt or wounded in some way. So vital information can be obtained without offending or pressuring a patient who professes not to have religious or spiritual beliefs. I like what Ken Pargament, our distinguished scholar, says. He says, we're all like onions. And as our patient care relationship develops over time, the onion gradually gets peeled. One layer at a time, the patient reveals more and more of himself or herself. And over time, a patient who says they're not spiritual or religious may in fact reveal some wound of the past in a church, synagogue, or setting, or temple somewhere, hurt them and they turned away, or maybe a loved one died, they lost a job, couldn't understand why God let that happen. But in fact, their spirituality may still be alive. That person may pray privately, may continue to seek after God, ask ultimate questions like, why did you let this happen to me? They don't want to tell you right off. So it's a good thing to remember we're all onions. I need to have a picture of an onion to add to this talk. Then I just want to mention there are a bunch of what are called scales to assess religiosity and spirituality. There are scales to measure what's called dispensational religiousness, and you see them listed there, spiritual well-being scale. There are scales to assess the religious and spiritual commitment. Is a person committed regularly to attend church, for instance? Scales that will assess religious and spiritual development. The last one on the list is interesting to me because James Fowler has done so much work on faith development, how it happens in life, and there is even a scale now, a test that can be utilized to see where a patient is along James Fowler's faith development. And then there's another set called measures of functional religiousness. These scales assess religious and participation. You see them, the religious involvement inventory and an attitude toward church scale. Then there are scales to assess religious and spiritual private practices, the things I do individually, not in a corporate setting. There is a list, and there's some for, if you're a Jewish religious observance scale, there is Christian ones, and there's a Buddhist belief and practice scale. These are found, Peter Hill has written an article, it's in the Handbook of Psychology, Religion, and Spirituality, and you can find it there. There are even more scales. These were the principal ones I wanted to add. Care is only as good as the care plan. The care plan is only as good as the assessment of needs. So that's why what I've been talking about is all the different resources that are available to help us in the assessment. It can be as simple as the 4 questions we heard mentioned earlier. But it can be also as complex or helpful to do some of those scales, do some of the assessment tools that are available. Planning. Planning care should be the second nature once the need has been established in an assessment. And many practices in medicine are standardized. If you have a broken leg, we're going to reduce the fracture. If you've got a laceration, we'll suture the cut, dress the wound. Strep throat, you're probably going to get an antibiotic. And a spiritual care plan can be a little more difficult, not as specific and easy. Often spiritual needs are listed on care plans and wind up really being called psychological problems because, say, a patient is anxious. But why are they anxious? What is beneath it? What's behind it? It may be a spiritual issue. So it's helpful to discuss with the patient himself or herself, discuss the problem, and if it is a spiritual need, let them verbalize it a little more specifically so it can be addressed properly and with some rationality. Just jumping off in your own idea may not be the best approach. May get resistance from the patient, in fact. So planning requires good communication in the care team. Passing information about patients' thoughts and feelings should be handled carefully to avoid boundary violations and confidentiality violations. This kind of information cannot always be put in writing in the chart. In fact, you may not want to, but you would be able to talk with the team members. It's real good to have case conferences, oral reports, dialogue among the team, so you don't have to put everything in writing if you're not comfortable to do so. Healthcare professionals, patient and family and friends should have the opportunity to discuss any spiritual problem or need that's obvious and be able to look for ways to solve it together. It's very helpful that the patients not be just told what we're going to do about a spiritual problem. It's brought into the open and discussed together. Healthcare professionals see themselves as experts at planning. But in the case of spiritual care, it's often someone who knows the patient best that may be the best person to suggest the plan of care for a spiritual problem because they know what will be acceptable to the patient. The care team may not have any clue. So you have to level this expert idea down to the level that we're all together in solving these problems. But once we bring to fruition a plan of care, it's certainly a skilled task. Needs and care must be prioritized so that the right care is given at the right time. But that's generally what we do when we're taking care of biomedical problems. We have to prioritize when it's the right time. In those cases, we have a task. We know exactly when it's starting. We know when this treatment will begin. We'll start with that one, and we have a plan very carefully. But the point I want to make is spiritual care is often not like that. You can't say we're going to do it here, we're going to do it here and there. It's going to be an ongoing process because you build relationship with a patient over time. It builds up, and as the trust level builds up and develops between the patient and staff. In a large hospital setting, a patient may be taken care of by a team of multi-specialists. It may have as many as 12 professionals. Each will only spend a limited amount of time with that patient, maybe only just a few minutes. And even when you have a named nurse and they put it, they write it on the blackboard in the patient's room, the constancy of relationship with that patient and that nurse isn't necessarily guaranteed. It may often be very fragmented, the time. The reason is the nurse has chart responsibility. She has a host of other patients to take care of, and we really can't guarantee that named nurse is going to be able to be the one that provides spiritual care for this patient. And if no one else is doing it, it simply will not happen. This will lead to a patient feeling dissatisfied, unsatisfied, and even apprehensive without being able to say why. A patient may say, there are all these people that come in, they talk to me, and they leave. Half the time I don't even understand what they're talking about. And that's generally the case. And for this reason, spiritual care must be intentionally implemented alongside physical care of the patient, the biomedical. It then becomes a part of a natural caring process. And the responsibility goes to all members of the care team, not just to that one designated nurse. So you're going to see we're going to have to do something if that's going to happen. There are times when resolving a patient's spiritual problem may take priority over, in fact, a physical or even psychological one. They may be dealing with a spiritual problem that may, in fact, if we deal with the spiritual problem, will resolve the psychological or physical issue. There are many evidences that when we have particularly an ultimate spiritual question, like, God, why did you let this happen to me? Pain goes up, suffering goes up, psychological issues, anxiety is heightened. So by dealing with the spiritual problem, these other issues may immediately, if not evaporate, be greatly improved. This has been well documented in literature. Looking at pain control, this particular study, I don't think I need to mention it except to say that once in this particular study, what they were looking at were psychological problems and the social problems. And when they dealt with those, drug therapy was greatly reduced for pain. The point is the patient needs to have some sense of control over the process in order to be self-maintaining as possible. It's also the case with spiritual problems. That was true with pain management, where a patient is worried about being able to return to a normal life after an operation. This patient's problem can be dealt with preoperatively. We can begin to talk about it. We can begin to let them know we understand this is an issue and that we're a part of this journey that you're going to be making. And that alleviates a great deal of anxiety. The patient may feel that his life may not be worth living if he couldn't return to the same job. Or what if he couldn't play golf with his golf partners? Looking, and you know, that sounds trite, but it's absolutely true. Looking at the physical constraints that the operation may put on the patient and then helping the patient to deal with them will help him recover faster and with greater hope. Sometimes when dealing with spiritual problems, healthcare professionals have to defer to the patient's greater knowledge on how to deal with a problem once it's identified. The patient needs to be listened to. They need to be included in the conversation. It may not be the team leader or the most highly qualified member of the staff that's prepared to deliver spiritual care. In some cases, a support staff person may be better suited than the professional to deal with spiritual issues. I'm going to tell a little story. I know a pastor that said his secretary had recorded all of his sermons, typed them all up for years. She had a problem, a spiritual problem. She didn't go to the pastor. She went to another staff person who was very open. And this pastor told me, he said, I realized I was not open to her. She didn't feel comfortable coming to me. That's exactly what happens in many cases with our sophisticated medical science team. Patients don't feel they can bring this to them, but if it's identified, there may be a staff person, maybe somebody that's very spiritually attuned on the staff of the hospital that would be better able to deal with these matters, and certainly there's always the chaplains available. It's important that the team leader recognizes when this is true and helps facilitate such a relationship. And thus the importance of all members of the healthcare team must be emphasized. There are no hierarchies when we come to spiritual management. They shouldn't be allowed to interfere with what is done. So, without a plan of action, we should not be surprised where we end up. We need a plan to meet the spiritual needs of our patients, as with every other aspect of patient care. So that I've been talking about the plan. Now I want to look at evaluation. All patient care must be evaluated to see if the goal is achieved. Evaluation is vital because it allows review, encourages adjustments, changes in the care plan, and other matters that will enhance patient care for other patients in the future. Yet it can be hard to evaluate spiritual care, the effectiveness of it. Only a small number of standards can actually be audited, so the evaluation process may seem so imprecise people don't want to engage in it. The best way to evaluate spiritual care is to record cues from the patient before discharge. The patient's sense of well-being, not being anxious about their care, getting back to normal. Do you see that happening? Or do you find just the opposite? The patient is distressed, anxious, afraid to go home, don't want to leave the hospital. Or are you sending me home too soon? Do they refuse to meet with family members, priests, chaplains, other staff members while they're there? Were there things going on? And that, just before they leave, gives a real good idea of whether spiritual needs were addressed during the hospital stay. The difficulty with evaluating spirituality is it's seldom just cause and effect. With a headache, we take a pill, we get relief. And that's an objective finding. All you have to do is ask the patient, is your headache better? But a spiritual evaluation of patient care is much more subjective and can be complex. The cause of spiritual distress may be internal bitterness or unwillingness to forgive someone that hurt them decades ago. The patient may even deny that that is the case. So spiritual problems are not easy, they're subjective. And remember, every patient is that onion. The hospital stay may be short. Today it is, getting shorter and shorter. There may be insufficient time to develop a strong patient-caregiver relationship that leads to trust. So that the onion could be peeled sufficiently. So that's just part of the facts of the reality, and we need to not be afraid to acknowledge it. The patient was only in 2 days or 1 day, but that's the reality of it. However, having said that, dialogue with the patient and other team members is the best way to come to this final spiritual evaluation. Consider when the team comes together whether or not the patient reacts to the environment in the same way as when they were admitted. Since he's been in the hospital, can he communicate more readily, express needs and concerns better? Does she seem more at ease now at the end of the hospital stay? How does the patient react to staff, family members, and guests during the stay? And did the patient receive a chaplain visit? If so, what was the result of that? And you would want the chaplain to be there for this final discussion, this evaluation. These are the kind of questions that a team should consider in their final evaluation as to whether or not spiritual assessment identified a spiritual problem and how well it was addressed during the hospital stay. So every plan for patient care must be evaluated to see if it's achieving the result intended. The evaluation will allow the plan to mature over time and become more effective, particularly for other patients. I want to mention very briefly that making a genuine connection with the patient, I mentioned that earlier, that assessment begins with the caregiver. I want to look at this connection with the patient in a little more detail. One of the most common causes of patient suffering is the failure to connect with their caregiver and with their loved ones. For the family, this is especially true in cases of sudden and unexpected death. Many of us will say, I tell you what, I want to die in my sleep. That's really a bad idea. You never get to say goodbye to your loved ones, and they don't get to say goodbye to you. And if there are issues that need to be reconciled in broken relationships, there's no time to repair them. Sudden death is not the way to go. Suicide, in fact, leaves families totally distraught for decades. Cannot tell you how many families have a young son, often bipolar, who commits suicide, and families are just totally wiped out. And they keep asking those what-if questions. What did I do? So the fact that we need to continue this communication process and connect patient with family and also hospital is important. Why patients need this is they are vulnerable when they come to the hospital. They're suffering. Some may be facing death. They may or the operating room. They not only need the best care, they also need to have comfort, reassurance, affection, and love. And that can happen in the hospital setting by the caregivers, and should. But too often just the opposite happens, especially when, say, a family member comes in with a load of heavy emotional baggage. They bring burdens to the patient instead of meeting the needs of the patient. I heard someone yesterday tell me that she had planned to go eat out with a friend, called the friend to set up the time. The friend started talking about men were bad in this friend's, men were all bad. She used curse words, and the woman who was talking to me said, I don't need this. She did not make the appointment for that evening, which I think was probably smart. But this happens in the hospital. People come in and they're trying to change the subject. They don't want to deal with cancer if the patient has cancer. They don't want to deal with terminal issues. So they come in with, let me tell you what Uncle so-and-so did. We don't need that kind of thing, but it happens. So the healthcare professionals need to be aware when this is happening, and you won't be aware if you're not talking to the patient. They need to then be able to provide comfort, reassurance, affection, compassionate love when the patient needs it, and not by intervening with the family. I mean, you can't get in the middle of those things. Genuine connection with someone has qualities about it. Openness to communicate without expectations. Boy, expectations are the biggest problem in communication, I about know. I see it all the time. People expect something from someone else, and when they don't do it or don't say it, they are wounded. But it was their expectation that caused the problem. So being open without expectations is important. Truly listening in order to truly know the other person. Realizing connection is a special, sacred moment. That if you feel that holy awe in a conversation with somebody, it is a sacred moment. And it's blessed. It'll make your day. And then a willingness to reveal oneself when it's appropriate, but not burdening the patient with your issues. So you don't bring your stuff in, but you can appropriately at times reveal yourself to be a human being and not just this figure of a professional. To make a genuine connection, we only have to be natural and speak from our heart. Nothing forced. It's just the same thing with prayer. You don't have to do some ritualized form of prayer. You just speak from your heart to God. Same thing with when you're talking to a patient. Someone has suggested a meditation to make a compassionate connection before you enter the patient's room. And the meditation begins by seeing the other person as another you, not as a patient that's sick, not as a hurting soul, except both of you may be hurting. So another person like you, just another person. And you say that, now this is a meditation you do before you go in the room. You do it off by yourself and you say, I see this person just like me. And then I exchange places mentally with that person. Put yourself in their shoes, their situation. You know where they are. You should know their suffering. So you imagine, you put yourself there. I could see, what if I had this disease? And then with that perspective of the other person, of the other person's eyes and what they're seeing, ask yourself, what would she or he most want from me? Ask yourself, what would she or he most need from me? And if you do that, when the meditation ends, then you go in, you will be prepared in your heart for a compassionate response. You'll remember that you have no expectations and you do not judge what happens in a harsh way. By that, I mean nothing may happen. You may have done your meditation and in your mind the patient wasn't ready to receive, but that's okay. You're laying seeds that will bear fruit in the future. I'm going to finish with, just wanted you to know that in this book, Making Healthcare Whole, Christina Puszczalski and Betty Farrell have a list of a sample of spiritual healthcare interventions that we can do. I don't know if you can pull in a little closer on that with the camera, but just because it's hard to see, I think, up there. But I want to mention some of them. There are therapeutic communication techniques like compassionate presence. That's what I just mentioned to you. Reflective listening, where you query important life events, ask them, tell me more about that. Support patients' sources of spiritual strength. Do they have a religious community or whatever? Open-ended questions to elicit feelings. How do you feel about this illness? Inquire about spiritual beliefs, values, practices, life review, continued presence with that patient and follow-up. And then therapy is referral to a spiritual care provider, maybe a chaplain. There are techniques like guided visualization. At MD Anderson, they offer almost all of these: guided visualization, progressive relaxation, breathing practice, meditation or contemplation, meaning-oriented therapy, the use of storytelling, narrative, and then dignity conserving therapy. There are sort of things as well as self-care practices that can be taught to patients: massage, reconciliation with self and others, spiritual support groups, meditation, sacred readings and rituals, yoga, tai chi, exercise, art therapy, music therapy, art and dance, and then journaling. And over at MD Anderson Cancer Center, they have a team of people that offer these to patients, and I want to suggest that is a terrific thing. I also want to mention a little expansion on the what is called spiritual care provider, the chaplain or a pastor. There are interventions like, of course, visiting the patient and family, praying with the patient, discussing spiritual matters of concern, having Holy Communion or some other ritual, blessing the patient. And there is a list we have of over 96 different chaplain interventions that chaplains can do in patient care. So I just want to mention that. And finally, we want to put this spiritual care on the care team's agenda. We want to enhance, if we want to enhance it, one of the first things we've got to do is put it on their agenda. And I mean the agenda at the senior management level, the board level, the care team level. The board of the hospital needs to know that it's being done and appreciate it. Above all, it must be on the team's agenda. Today, healthcare provision is based on business principles and evidence-based studies, too often maybe. Decision makers need to know that over 3,000 articles have appeared in the literature that show a positive correlation between spirituality, health, and healing. And surveys reveal patients feel understood if their spiritual concerns are recognized and treated with respect. Their sense of well-being, trust in the care they're going to receive in the hospital, compliance with treatments that are recommended, all of that is affected. So it needs to be on the care team's agenda. The spiritual care does. Spiritual care needs of the patient should be seen as part of the core objectives of patient care, not just an ancillary thing, not just a happenstance when occasionally it happens. No, it needs to be thought of often. And an educational strategy can be developed and endorsed by the hospital leadership that will ensure spiritual care has reached a high level of priority on the agenda. Caregivers at every level have the responsibility to raise an issue in a setting with other healthcare professionals. Whenever they recognize there is a spiritual issue, they should, at every level, no matter who it is, maybe an orderly in the hospital, they should bring it to the team. And hopefully the team will listen, learn to listen. This is a little hard to see, but I want you to know in the book Spiritual Challenge of Healthcare, there is a nice little schematic plan. Starts with forming a steering committee, developing a philosophy of care and mission statement, identifying the existing situation, knowledge and skills that are available, discussing it with the staff, discussing it with focus groups, raising staff awareness, developing standards of care, identifying training needs, developing a training plans, adding to business planning process, the spiritual care, review existing resources, delivering training, and finally auditing, or that's the review, and looking at the current situation again and again. It's a nice little summary, schematic drawing of what can be done to help facilitate this process. So, in review, one of the important things to enhance spiritual care in a hospital setting is recognize healthcare as a calling, a sacred vocation, develop a 4-step process, develop training so the healthcare givers have the skills they need to function comfortably with our patients, and then put spiritual care on a healthcare team's agenda. And if you do that, I think you will enrich your hospital. You will reach those levels of suffering and pain that patients bring to the hospital, but otherwise would not even be recognized. Next week, we're going to look at spiritual care of the aging and the end of life. I welcome you and hope you'll come and be a part of that. Thank you for your attention.